Good afternoon. Welcome to this voting session for the House Health Committee. This is Friday, March the 6th, voting list number 5. We're going to start with, we have one withdrawal. Do we have a motion on the withdrawal?
Move the withdrawal.
All right, it's been moved and seconded. Any further discussion? Seeing none, all in favor, say aye. Aye. Anyone opposed? Go ahead and raise your hand. All right, so our first bill on our voting list that's not a withdrawal is House Bill 377. This is physician assistance parity with other healthcare practitioners. This is Lindsay and Rosenberg.
This bill authorizes a physician assistant to perform numerous additional duties as specified, requires that health maintenance organization quality of care standards include a requirement that each HMO member has an opportunity to select a PA as primary care provider from among those available to the HMO, adds a PA member to the statewide advisory commission on immunizations, and excludes a PA from the definition of healthcare practitioner with respect to healthcare staffing agencies. There's a reprint of the bill beginning on page 1 in your packet, with amendments adopted in subcommittee that remove from the bill provisions relating to involuntary admissions, includes certified nurse midwives and licensed certified midwives in the list of healthcare providers who can order a pregnant incarcerated individual admitted to an infirmary and to the list of primary care providers a member of an HMO may select, and then also requires the MHCC to, as drafted right now, collect data on the average length of stay in emergency departments for individuals who are subject to an application for involuntary admission, and evaluate whether there's a longer average length of stay for individuals who are brought during an overnight shift to EDs that lack a sufficient number of clinicians with authority to certify an application for involuntary admission, but are staffed by physician assistants, and then report that back to the General Assembly. The reason I said the way it's worded now is that was the way the amendment was voted on by the Health Occupation Subcommittee, but Delegate Johnson has suggested a one-word change to that amendment. So if you are looking at page 13 in your packet, the new language is section 2 at the bottom of the page, and about 3 lines down, it says the MHCC shall collect data on the average length of stay, and Delegate Johnson would like to suggest changing that collect to review data. That's because MHCC is already collecting this data, so that would be redundant. They should review this information.
Delegate Rosenberg.
This bill is the result of the compromise that the sponsor spent a significant amount of time with all the affected parties to reach the consensus that is reflected by the bill. It's already current law that either 2 physicians, 2 licensed physicians, or 1 licensed physician and 3 other categories of healthcare practitioners can co-sign, and this adds 1 licensed physician assistant to the list of those who can co-sign. The vote in the committee was 4-2, and I guess I would move the amendments.
Right, amendments have been moved and seconded. Are there discussion on the amendments? Delegate Shalega.
Thank you. Was this suggested by the Psychiatric Association, this new review? They were the ones that were mostly opposed to this, right?
When you say suggested, I'm not quite sure what you're asking.
Well, does this, and maybe.
The sponsor can speak
Delegate
to that
Johnson.
better than I can.
No, this was HSCRC already collects the data. So then they informed us they collect that data. So then that left the Healthcare Commission that would just review that data that they collect, because they already collect it.
And report it to us, or what do they?
Yeah, and then they would report it to us by, I think it's December 1st, 2020, November 2026.
Okay, and so on that amendment, I'm fine. Then I'll have another question when we're done with the amendment. Thank you.
All right, so we're still on the amendments. Seeing no further questions on the amendments, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Now, do we have a motion on the bill as amended? All right, it's been moved and seconded. Now we'll open it up for discussion. Delegate Shalega.
Okay, thank you. Is there a mandate in here for additional length of stay? No? That that patients will stay additional time? No? I thought that was in here. Okay. And finally, in the end, where was the Psychiatric Association or Society?
We can defer to the sponsor because he's been having extensive conversations.
Yes, he has. He's done a good job.
They came in with a whole list, and we made some accommodations for them. Asking for the information was one, and then another thing they wanted us to do was, right now, when you pull up an admission form, it shows 3 people that are authorized to be the second signatory. There's another 2 positions by law that are authorized. They ask us to write the hospital association and ask them to put those other 2 on the admission form. So we did do that, sent a letter to do that, so to get those other 2 positions on the admission form. Some of the other stuff really didn't apply. They kept going back to involuntary admission, which we took that out of the bill, so that did not apply. They talked about what if a voluntary admission turns into an involuntary admission. And I informed them, well, we took that out of the bill, so a PA would not be able to sign in that instance either. Because if it turns into an involuntary admission, the PA cannot sign.
Right, the
It's not in
involuntary's out, but the voluntary's in.
Correct.
And I remember Dr. Lewis testifying in our subcommittee as well that she still had concerns, so.
Yeah, but she kept taking the conversation back to involuntary.
Okay.
And that's out of the bill. So she said sometimes a voluntary admission can turn into an involuntary admission. Well, involuntary is not in the bill, so a PA would not be able to sign in that instance anyways.
Thank you.
Delegate Hutchinson.
Thank you, Madam Chair. If I can ask the bill sponsor, how do you see this helping rural health and also ED wait times?
In the rural areas where they have less people that are authorized to sign admissions, it's going to give them another tool, another person that can expedite an admission. So especially in the rural areas where they only may have 1 physician on staff, they may not have the other folks that are authorized as signatories, especially at night. So this would help expedite admissions and get people the care they need.
Thank you.
Delegate Alston.
Thank you. I don't know who the question is for. It might be for council, but on page 4 of the bill, it's talking about for children and adolescents being admitted to a state facility. I'm just trying to understand who we're actually talking about. Are these children that have been deemed juvenile delinquents, or is it children who the parents may be seeking care for? Because I noticed that it's now physician and a psychologist, but we're adding physician and physician assistants. And because it's a child, they can't necessarily consent. So I'm just trying to understand.
Provision that deals with voluntary admissions, but you're right, because it's a child, it's voluntary for the parent or guardian rather than for the child themselves.
Okay. And I'll ask the bill sponsor, would you consider it friendly to take it out for the kids? Because we took it out for the adults. The part about the physician assistants. I don't want to, I like a lot of what's in the bill, but I would be concerned about letting a physician assistant do the paperwork where we said they can't do it for adults, but now we're going to let them do it for kids. Or am I reading it wrong? It's involuntary.
Yeah, that's only
Involuntary.
for involuntary.
But these are children, and that's what I was just asking, because children can't voluntarily.
Yeah, it has, one of it has to have a signature of a parent or a guardian for a child or a disabled person. Does that answer what you're trying to get at?
It does, but I think my point is they can't consent because of their age or capacity. So they can never voluntarily do it. It's always, just based on the law, they're not going to be able to voluntarily consent to these things.
That's why it has to be a parent or guardian.
Right. And that's where my concern is. because it may be against their will, and I would want them to have the highest level of possible care when we're going to involuntarily commit them. Just like if we are involuntarily committing an adult, we want it to be a physician and a psychologist. If we're going to involuntarily commit a child, I think it should be the same thing.
But the involuntary piece is out of the bill.
It is, except right
And I
here.
get what you're saying, but I'm not so sure, does that qualify as involuntary?
I mean, it's grouped under voluntary admissions because it is the parent or guardian who's consenting to it. But this is a policy question for you all.
So the question is, can a child consent on their own volition? No, so it's involuntary. But it is a policy question.
It is a policy question.
I am
and
not,
I think the question around this is, like, what is the problem that we're trying to solve? And by eliminating that, does that create a greater barrier to getting into care? Because this is under the voluntary admissions, correct, for adolescents. But one of the issues that we're having is getting kids into care in a timely manner. So I think that is the policy that we're considering.
I understand, but I don't think that the problem is getting people to sign off on their paperwork. The problem is we don't have the beds. I don't think the problem is we can't find a psychiatrist and a psychologist to sign off saying that these children need to be, to have care. And I'm concerned about a physician's assistant being able to do that in place of a psychologist when it's a child. We've taken it out for the adults. I'm just asking that we take it out for the kids too. And I'm fine with the rest of the bill. I would just be concerned.
Yes. Now, I'm not a lawyer, so this seems like more of a legal question because they fall under the voluntary since they're being signed by a parent or guardian. But I mean, I understand your point. I'm just not so sure legally where that falls because a child, they can't agree to have immunizations or shots. They can't agree to do a lot of things that are left up to the guardian or the parent. So I think that's where this falls.
I agree. They can't make those determinations. They can't consent to these types of treatment, which is why if they're going to be committed for a emergency evaluation, a psychiatric treatment, that it should be two licensed doctors, the psychiatrist and the psychologist, or the physician and the psychologist, or whatever we're doing now just for that purpose, so that we're not looking at possible infringements on children's rights, which they may or may not even have. I just think if we should be consistent with the way we did it with the adults, that's all.
I think we understand the argument. We're going to open it up to discussion. Let me go, yeah, with that. Delegate Hill?
Yeah, actually, I think I see Delegate Austin's point, and I'd like to sort of approach it a different way. I think what Delegate Austin says, we recognize for adults, even with voluntary admissions, that we want people who actually are trained and have a particular understanding to sign off. That's first of all why we have two people sign off. And if we do that for adults, why would we have a lesser standard? For example, we've specified in this statute, on top of page 6, current law, that, page 5, that it can be a physician and a psychiatric nurse practitioner, not just any old nurse practitioner, a physician, a licensed certified social worker clinical, not just any social worker, and a physician, a licensed clinical professional counselor. So we're very clear that they actually have to have training. PAs are physicians extender, and I think this whole bill assumes that whatever they're doing, it's under their delegation contract, although there's nothing in here that says that the PA who does any of the things we're allowing has to still be working within the restrictions of the delegation contract. We're taking that as a given. But if we've taken so much care with adults to make sure that that second signature is actually trained on a voluntary adult, why would we take less care with a child? I think that's the question. It's not about whether they can voluntarily be admitted and whether a parent's involved. The parent's going to be involved. But the professional signatures, what she's asking is, why would we ask for a professional signature for an adult to be more restrictive than the professional signatures that we're requiring for children?
Delegate Hutchinson.
My question was answered.
So Delegate Alston, would you like to offer an amendment and we can discuss it conceptually while we're would you like to offer an amendment?
Strike line 28 on page 4 of the reprint package.
So,
Just to clarify, since that's the only change in this section, we would just strike the whole section from the bill.
Oh,
Because this section doesn't need to appear in the bill
Okay.
if that change is not happening.
all right, so we want to open it up for discussion, that it's been moved and seconded with clarification that the amendment would actually be to strike this section from the bill, so we would just be silent on voluntary admissions for adolescents. All right. It would be current, yes, it would simply revert back to current law. So it's been moved and seconded. Do we want to open this up for discussion? Yes. Vice Chair Cullison.
Thank you, Madam Chair. So does this whole section no, it's 10-610, or 6, yeah. That's the section you're talking about? That's what, just that would be eliminated?
Yes.
Okay, all right, thank you for that clarity.
10-610, and then starting at 10-611.
Right, okay.
Striking lines 19 on page 4 through line 5 on page 5, and then make the appropriate function paragraph change as well.
Okay, thank you.
All right, so this amendment has been properly moved and seconded. We had the discussion. So we'll take a vote on this amendment conceptually, understanding that we will make sure that it's cleaned up by the time we get to the floor report. All in favor for adopting the amendment, say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, seeing none, we now have, do we have a motion on the bill as amended and amended? All right, it's been moved and seconded. Any further discussion on the bill as amended? All right, seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, it passes unanimously. Is there anyone who does not want to be on this bill? Go ahead and raise your hand. Delegate Shalega, Delegate Morgan, Delegate Hill, Delegate Hutchinson, Delegate Riley. Thank you very much. All right, we are going on to, and I also just want to take a moment to thank the bill sponsor, who I know has been working on this issue, working with the stakeholders, bringing everyone together. And thank you also to the subcommittee, because I know you all did a lot of work and time on this. All right, House Bill 457. This is Institutions of Higher Education Provision of Menstrual Hygiene Products Requirement. We are second on this bill. It is in appropriations. So Chris, if you can walk us through the bill as amended.
This bill requires each institution of higher education to provide free of charge menstrual hygiene products in all restrooms by August 1st, 2028. The bill takes effect July 1st of this year. The Appropriations Committee did send over amendments, Amendment 1, and the amendments are in your packet on pages 16 and 17. Amendment 1 is technical. Amendment 2 changes restrooms to student health center and only requires higher education institutions with on-campus housing to have menstrual products in the student health center. The designation on-campus housing excludes the University of Maryland Global Campus and most community colleges from this requirement. 2 community colleges, Allegheny and Garrett, have on-campus housing in a student health center and therefore will be required to provide the menstrual products with this amendment.
All right, so we are, do we have a motion on the bill as amended, knowing that we are second? Okay, so we don't have to vote the amendments because we're voting the bill as it came over from appropriations. So it's been moved and seconded. Any discussion? Delegate Shalega.
Thank you. I understand that the schools are already doing this.
I don't have any.
Okay. All right, I think it's a bill about nothing to make people feel good. Thank you.
Sometimes we do need that. All right. Well, we are second on this bill, and we did hear from the bill sponsor who said she would like us to move the bill. So we all in favor say aye. Aye. Anyone opposed? Go ahead and raise your hand. Delegate Shalega, Delegate Morgan, Delegate Riley. All right, so it passes not unanimously. We will send our vote list over to appropriations. Thank you, everyone. House Bill 520. This is State Board of Physicians Naturopathic Doctors Scope of Practice Renewals and Professional Liability Insurance. This is Lindsay and Rosenberg.
This bill expands the scope of practice for naturopathic doctors to include dispensing specified drugs and devices, including controlled dangerous substances, and expands the grounds by which a naturopathic doctor may be disciplined by the Board of Physicians. The name of the Naturopathic Doctors Formulary Council is renamed the Naturopathic Doctors Formulary Council for Controlled Dangerous Substances, and the formulary is redefined as a list of CDS for use by licensed naturopathic doctors. The bill removes a requirement for licensed naturopathic doctors to provide evidence of biennial CPR certification to renew a license, and it also establishes certain requirements for the public profile of a naturopathic doctor and requires a naturopathic doctor to notify a patient in writing if they do not have professional liability insurance coverage or if the coverage has lapsed. This bill is considered in health occupations with no amendments.
Delegate Rosenberg, followed by Vice Chair Cullison.
Yes, the bill moved unamended as a recognition that this is an appropriate expansion of scope of practice for naturopathic doctors, and the vote was 5-2, unamended.
Vice Chair Cullison.
Got it. There we go. Thank you very much, Madam Chair. I suspect that you have received an email from physicians in your districts that are the result of an email that was sent out by their organization, MedChi. And I would like to take this opportunity to respond to that message. As a former union president, I understand strong lobbying tactics, and they're certainly within their rights and to do this. But what I would expect from them is that the information would be correct. And so what I would like to do is correct the information in the document. There's a claim that this new legislation would expand naturopathic doctors' authority by granting prescription rights to virtually all medications, including controlled substances, chemotherapy agents, psychiatric medications, and antibiotics. On the other hand, if you look at the legislation, it provides for prescriptive authority for medications, not controlled dangerous substances, because that would be controlled by the Formulary Council, that are within the scope of naturopathic doctors, not chemotherapy agents. This would definitely not be within their scope. For controlled dangerous substances, the Board of Physicians could, but is not required to, authorize naturopathic doctors to prescribe a CDS by placing the medication on a formulary. The Board of Physicians would have to approve each CDS and ensure that it was within the scope of the naturopathic medicine. This means that physician-led board would have the final say on the list, and I expect it to be very narrow. I'm told by the naturopaths they are really not interested in prescribing CDSs themselves, but we left it because medicine is changing. MedChi says, this represents a substantial expansion beyond current scope and raises serious patient safety concerns. I frankly took great umbrage at that statement. You all have known me, many of you have known me for many years, and you've known that I believe, I hope that you know, I would never put patient safety at risk. But as I presented in the hearing and in my testimony, in states where naturopathic doctors have this authority, most states have 0 complaints related to naturopathic doctors and prescriptions. Where they have broad authority, and there are states that allow them to prescribe opioids, there are some complaints, but still minimal. I've asked the opponents for actual data on the concerns they've raised, and I haven't received any. One of the claims in the email is that nurse practitioners are required to complete an 18-month mentorship before being certified and able to prescribe, while naturopathic doctors can prescribe immediately after licensure. This is factually incorrect. New nurse practitioners do not have to practice 18 months to be certified or to prescribe. To become certified, new nurse practitioners must attest to having a mentor for 18 months, but there are absolutely no restrictions on their practice or their prescriptive authority. That's actually the result of a bill that I passed back in, I think, like 2017, 2018, and we haven't had any issues with that. It's been in law for over 10 years. I don't understand how this could be clearer. I have to note, one of the other concerns that they mention in the email is that naturopathic is one silo of medicine and allopathic is another silo. I would suggest to you that these do not need to be silos, that they can indeed work together. And so I do not understand that separation. When we were clear that the education that naturopathics get is very similar to regular allopathic medical school. And, the only thing they don't do is a residency. I think you all know that I have a collaborative work style. I have spent the last 12 months holding an inclusive work group this fall with naturopathic doctors and allopathic doctors in a work group. I understand that we're not always going to be in agreement, but I think it's important to be as accurate as possible when you put out this kind of information. So I appreciate you considering this as we consider this bill. But I am going to, in the spirit of collaboration and trying to get us closer and listening to my good colleague over here to the left, I understand that there is great concern from the allopathic doctors that the reference to controlled dangerous substances is problematic. I would like to propose to you that we strike that reference out of the bill and leave them with the prescriptive authority that is within their scope, and but include bioidentical hormones, because they do a lot of work on menopause. So they need to be able to prescribe like estrogen, testosterone, things like that. Testosterone is actually a CDS. Don't ask me why, but it is on the list. So if we can include that, then I hope that we can come closer to getting this bill over the line. Thank you all for your consideration.
Would you like to move your amendment?
I would like to move the amendment I just described in concept. Okay.
All right, it's been moved and seconded.
Is testosterone in or out?
Well, the bioidentical is a hormone, includes testosterone.
So just to clarify, the bill was adjusting the formulary to be specific to a list of controlled dangerous substances. So with this amendment, we're going to also remove any references to the formulary and the formulary council. So we'll remove all of those references from the bill as well. And then right now, the naturopathic medicine license includes, and if we're looking at the bill, we're on page 4, prescribing or administering. Item 2 was controlled dangerous substances, and we will just strike that and replace it with the bioidentical hormones.
Delegate Szeliga, followed by Delegate Hill.
I'm going to let Delegate Hill start. She probably has it better said than I would.
Delegate Hill.
First of all, Madam Vice Chair, I appreciate your working with me, and I also want to know, for you to know, and for the members to know, for the public to know, that my conversations with you about my concerns were not in collaboration with MedChi. I did not find out there had been a letter that had been upset until this morning, but I appreciate your working with me and clarifying things, because that really does address my concerns. So thank you very much.
Delegate Szeliga.
Maybe not. So what this bill will do is allow naturopaths to prescribe hormones, hormone therapy. That's it, nothing else.
They have to prescribe anything within the scope of a general practitioner. So things like blood pressure medication and cholesterol medication, antibiotics, they would be able to do those.
And they can't do that now?
No,
Okay,
they can't.
thank you.
Any further discussion? And I just want to say thank you again to our Madam Vice Chair and to our members. Sorry. Delegate Rosenberg.
Well, I think I'm going to say what you were about to say, and to thank the extraordinarily generous response, not surprisingly, of the vice chairman. She could have been upset, is the nice word for it, at the response to the bill. And she could have used her position to say, let's move forward. But she's reached out and put a compromise before us, and I will be glad to vote for it.
Delegate Morgan.
Thank you. Clarifying, and great job on the amendments. I think this is how the appropriate process is supposed to work. I think the bill's much better. But I did have a question with homeopath doctors. Are they, I mean, they're allowed, naturopath, I'm sorry. They're not precluded from working on children as well, right? Can you take your 15-year-old to see a naturopath doctor? Sure. Okay, thank you.
Delegate Hill.
Yes, so I also wanted to explain that in general, I have had problems with the bill, so I appreciate all the things I said before, because I feel as though naturopathic training is different. There's a lot of overlap. Homeopathic and osteopathic training is fundamentally different. I think that mutual respect for those differences is important, so that, as an example, as a MD, I refer patients to naturopaths when there are treatments that I think they can offer that I have no expertise in. And I am still concerned that what this will say for even routine things like blood pressure medication, which they presented as in an emergency situation, I do have some concerns about their ability to prescribe even routine things that we take for granted, and I have not been convinced that their understanding and training. I think it's easy to think that your understanding is the same until you're walking in other shoes, and I guess, I certainly could be, I've been wrong before and will be wrong again and may be wrong on this one, but I think it would be like my prescribing a naturopathic formulation and mixture for somebody to treat their migraines. I don't know enough about it. I don't know enough about how they work, and I just don't understand how they think that their training gives them that knowledge. So but that being said, as I said, the vice chair worked with me on my primary concerns, and so, I'm not going to vote against the bill.
Appreciate that. I'm sorry. Oh, okay. I appreciate that. I really do. But I just want to remind folks that the bill doesn't in any way change or impact or eliminate the requirement for a naturopathic doctor to have a collaborative agreement with an allopathic doctor. That still exists.
I believe we are on the amendment. So it's been moved and seconded. We've had our discussion. All in favor of the amendment, say aye. Aye. Anyone opposed, go ahead and raise your hand. To the amendment. Yeah, we're still on the amendment. Do we have a motion on the bill as amended? All right, it's been moved and seconded. Any further discussion on the bill as amended? All in favor, say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. Thank you all very much and thank you, Madam Vice Chair, for your thorough work. And as you can see, I don't love it when people come for our members. So I'm very grateful to the grace that our Madam Vice Chair has shown. Yes, who does not wish to be on this bill? We have Delegate Shalega, Delegate Morgan, Delegate Hill, Delegate Kipke, Delegate Hutchinson, Delegate Riley. All right, thank you very much, everyone. All right, House Bill 595. This is, once again, we are second on this bill. This is income tax credit for physician preceptors in areas with healthcare workforce shortages, alterations. This is Lindsay.
This bill expands eligibility for the state income tax credit for physician preceptors in areas with healthcare workforce shortages to include physicians who serve in a preceptorship program authorized by an accredited out-of-state medical school. The bill also reduces the minimum number of community-based clinical training hours for each of the minimum required 3 rotations from 100 to 90. There are amendments, page 18 in your packet from the Ways and Means Committee, that say that the aggregate amount carried forward from prior fiscal years must not exceed $100,000, which is the total amount that they're allowed to give out in the preceptorship tax credit. And the vote was, it was unanimous, 2 people were absent.
Well, it's because we're second, so we just moved the bill as it came out of the other committee. So do you want to move the bill as amended? All right. All right, it's been moved. Do we have a second? Second. All right, it's been moved and seconded. We'll open it up for discussion. Delegate Morgan.
Thank you, Madam Chair. I want to ask Lindsay a question. It's on the amendments that Ways and Means. So it's limited to $100,000? Or?
It says for each taxable year, the total amount of tax credit certificates that may be issued is $100,000. And so apparently they've actually been giving out like $30,000, so they're carrying forward a balance each year, and they're saying they can only.
I want to make sure I understand this. So that's not limited on the income, that's limited on
No, the tax credit that the state gives.
Okay, so they can't get more than $100,000 of tax credit in a given year.
Total amount of tax credits that the state will give us $100,000.
So, right, okay.
So it's not one individual getting $100,000 of tax credit. It's the total amount that the state's giving.
Okay, gotcha.
But they have apparently been giving out approximately $30,000 each year. So they've been handing
$30,000 out per year across the entire state for an incentive to go to these rural areas, and now they're upping it to $100,000?
No, they're not increased. The bill doesn't increase it at all. The bill is allowing the tax credit to go to a physician preceptor who's serving in a preceptorship program that's sponsored by an out-of-state school. So like GW, or MedCat gave the example of Pittsburgh, if you were like in Western Maryland. So the preceptor is a Maryland physician. They're working with a student in Maryland, serving Maryland residents, but the student might be coming from an out-of-state school. But the work is being done here in Maryland. So you can apply for the tax credit.
Can you just re-articulate what the amendment does? Because I think that's where we're.
The amendment is saying, so the tax credit certificates, if they don't give out that full $100,000, they can carry it forward. The amendment is saying they can't carry forward more than $100,000.
Okay, gotcha.
And that's because if they've been doing about 30,000, then you'd have 70,000 left. And then the next year, you can't keep carrying it forever. It would max out at 100,000.
Policy. Why are we doing this? Why are we giving a tax credit for this?
Well, the idea is to incentivize the preceptors to do the preceptorship work, and it does target underserved communities. And the idea is that if you bring in a student, even if they're going to an out-of-state school and they start working in Maryland, they will love it here and stay.
Okay, thank you.
Any further discussion? All right, so once again, we are second on this, so we're just voting on the bill as amended from the other committee. All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega, Delegate Morgan, Delegate Kipke. All right, so that passes. So we will send our vote list over to the Ways and Means Committee. Thank you very much. House Bill 804, this is Department of Aging, Aging Resiliency Fund Establishment. This is Lindsay and Lopez. This is the bill that we held from last week. Oh, Lisa, sorry, misreading my notes. Lisa and Lopez.
This bill establishes the Aging Resilience Fund as a special non-lapsing fund to support implementation of the Maryland Department of Aging's mission. The amendments that have been circulated include one amendment we passed around last week that strikes language that authorized the use of funds for administrative expenses and personnel. Since then, we have added some amendments that specify that the money in the fund is supplemental to and is not intended to replace state funding, that prohibits the governor from reducing an appropriation for the fund as approved in the state budget by the General Assembly, and requires the department to submit an annual report on the administration of the fund to Finance and Health.
Delegate Lopez.
Thank you. And thank you to Lisa for all of your work with the amendments on this and the back and forth. I think the amendments address the substantive issues that have been brought up, both in subcommittee and here and during the hearing. And certainly there's people who have different philosophical views about that. Those still stand, but the issues that we could work out have been addressed. And so I think we have a good work product. I'll move the amendments.
They've been moved and seconded. We want to open it up for discussion on the amendments. Seeing no questions, all in favor of the amendment say aye. Aye. Anyone opposed, go ahead and raise your hand. Do we have a motion on the bill as amended? All right, it's been moved and seconded. Is there further discussion on the bill as amended? Delegate Morgan.
Thank you. Hi.
Hi.
Hey, so did we get any clarification? Lisa knows. Did we get any clarification whether this nonprofit is just able to hold monetary donations, or can it hold like real property? If someone wanted to donate a house.
We didn't talk about that last week, so
I thought
we
we
didn't
did.
actually, not that specific.
What did we talk about? Wasn't it the business donating? Well, we can talk about that too. But yeah, okay, so yeah, I do remember that now. Now it was the concern over business deductions.
Yeah, I would say, just contextualizing, the fund is intended to take in money that can be used to further the programmatic goals of Department of Aging. And so if someone was going to contribute, a copy machine or a wheelchair, it wouldn't support the programs that have already been set up to do the work of Longevity Ready Maryland. So I don't think the bill prohibits real property, but I don't think that there's a way that Department of Aging could intake those types of contributions.
I guess my only concern on the bill, and look, I know what everyone's trying to do, and it sounds good in theory, but I am a little concerned that this is government creeping into the nonprofit space. And we've had so many issues with nonprofits, especially in the last year. Something just seems a little bit, to me, at least a little bit off on this. Now, I know there's an amendment that this is not supposed to supplement or supplant any other funding from the Department of Aging, but I got to think at some point, let's say this thing is super successful. I mean, that's absolutely going to happen. I mean, I just don't think there's any way around it. So it's just, something seems a little off. So, thanks.
Sure. To address your first point, all of these funds are going to assist in executing the programs as they occur or as they are intended to occur under Longevity Ready Maryland. So it's not like new nonprofits are being born from this. It's to execute the plans that have already been in place and have been a part of this 2-year process, right? So I would push back on the argument that it's veering into the nonprofit space because these funds are just trying to help the department execute what it's been trying to do. Secondly, the intention for these funds is to help supplement the department's budget given the variables in federal funding. So right now, they're $8 million short of what was expected, and so they're trying to come up with those funds. So again, all of this aligns with the department being able to execute the existing Longevity Ready Maryland plan. It's not creating anything new in that way. But appreciate the comment and interest.
Yeah, I think we're just in the philosophical thing.
No, we always appreciate the discussion. Delegate Riley.
Thank you, Madam Chair. I think this one, it might have been Delegate Schlegel, I don't know, I could be wrong, that asked this the last time. So I think in this year's budget, when there quite a bit of money that the Department of Aging had lost because it was shifted someplace else or money was taken from this year's Department of Aging in our budget process, and then now we're trying to, I don't know, recap that with the private industry. I do, I guess it kind of back to the, the reasoning, just have different thoughts on that. And then also, we discussed how this was supposed to be, I think we said we cannot put it in a special fund, because that has to go to the voters or something, or a lockbox. So how do we know that the monies that was just taking out of the Department of Aging this year, how do we know that this money, once we get it from private practices, that won't be taken?
There we go, Delegate. Thanks for the question. So to the second part of your question, there's a few guardrails in place. One, it says in the original bill how these funds are going to be used, and that is for existing programming or programming under Longevity Ready Maryland, right? So there's that. Secondly, we have amendments that say these funds cannot be used for administrative costs. Thirdly, we have amendment language that talks about fencing this funding. So outside of legislative session, the governor cannot touch those funds. That's as good of a safeguard as we can get outside of a constitutional amendment, and that seems like a whole lot of work for what we're trying to do here, right? Thirdly, there's an amendment that speaks to reporting standards, and so we have another safeguard at the end there. And so we've gone as far as we can to solve the problem that you're bringing before us with the tools that we have. And then remind me what your first
Just
question
to follow
was.
up, do we know in the past if there's been funds taking out by the governor when it was considered fencing? I never heard.
I would defer to Lisa on that, but I think, just generally, this is a new, the AFR is a new, or ARF, excuse me, is a new type of fund. So there's no precedent of taking money out of these funds before, because this is the first time this fund like this has existed.
All right. All right, thank you very much. Appreciate it. Thank you, Madam Chair.
Thank you very much. Oh, Delegate Kipke.
I don't want to belabor the point, but I know the Women's Commission, for example, has a foundation. And it just seems to me like a more appropriate way to handle this would be to have some type of foundation it would guard against some of the concerns and also, I think, would be a cleaner way of doing it. Thank you.
The contributor to the Women's Commission Foundation. Thank you for uplifting and amplifying their work. But yes, thanks for the comments.
I just want to say also thank you for the discussion, because I do believe that we've taken a good idea and made it better. So I really appreciate all the work that you have. We have the bill as amended has been moved and seconded. Seeing no further discussion, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega, did you want further discussion? Oh, okay. Let me just get it down. Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. And Delegate Shalega, did you want to go ahead and explain your vote?
I do, because I'm not going to do that on the floor. So, while I think this is a good idea, I was on the Maryland Commission on Aging for many years, enjoyed that opportunity. I'm a person that's moving towards being a senior citizen, unfortunately. But, I think it's said to help supplement the department's budget. If the government can't afford to pay for the aging population, there is a serious priority problem with our budget. Every year it goes up. This budget is $70 billion. We should not be asking the private sector to do what our tax dollars were meant to do, which is care for aging people. So that is why I'm against it. And I think you'll find out this program will be like others, that it just never gets off the ground. Thank you.
Thank you for your comments. And I know we have philosophical differences and discussions in this committee, and we always welcome them. This is favorable with amendments. Who would not like to be on this bill? Delegate Shalega, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. Thank you, everyone, for the discussion. We're going to move on to House Bill 811. This is Aging in Place Programs, Grants, Multi-Generational Third Places, the Village Multi-Generational Third Places Act. Lisa and Lopez.
This bill authorizes the Maryland Department of Aging to make grants to nonprofit organizations and area agencies on aging to support social connection for individuals in aging in place programs through events or gathers at multi-generational third places. There are no amendments to this bill.
Delegate Lopez.
And it passed subcommittee with unanimous support. So move the bill.
All right, it's been moved and seconded. Any further discussion on the bill? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega, Delegate Morgan. All right, and this is favorable, so we cannot do co-sponsors, yes. House Bill 866, this is Office of the Deaf and Hard of Hearing Case Management Services, Chris and Hill.
Originally, this bill was about case management services, but we had a amendment from Delegate from Delegate Kaufman that strikes the bill and instead extends the work group for the deaf, blind, and hard of hearing for an additional 2.5 years.
Delegate Hill.
With the amendment, which was unanimously moved, the bill unanimously moved, and the fiscal note went away because the governor's office of deaf and hard of hearing say they can handle it.
Move the amendment.
All right, amendment's been moved and seconded. Any further discussion on the amendment? All right, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Do we have a motion on the bill as amended? All right, it's been moved and seconded. Any further discussion on the bill? Delegate Shalega.
Thank you. So I know, as we all do, there is an Office of Deaf and Hard of Hearing in the governor's cabinet. I think their budget's $1.2 million. Why aren't they doing this? Why do we need a separate work group when we have a whole department that does this?
Well, actually, Delegate Shalega, when this bill was originally proposed in 2024, you were the floor leader on my bill. And all of this, all it does is extends the work group because they need more time to consider recommendations. Because for people who are both deaf and blind, meaning they cannot see and they cannot hear, it was found that the state wasn't doing enough for them. So there's a whole bunch of different recommendations that they're working through right now, and it was going to expire in June, and they need more time.
But I guess that didn't answer my question. Why isn't the Office of Deaf and Hard of Hearing doing this within their budget and charge of what they're supposed to be doing?
I think it's because they wanted to hear from the community and expertise as to what more needs to be done. They wanted to, there are a bunch of people who are deaf, blind, and deaf on the committee and are on the work group, and they are all, chiming in with, hey, this is what I'm dealing with. So I think it was, they could have this work group so they could get input from the affected constituencies.
And the bill strikes the 3 case managers.
Yes.
That was quite expensive in the beginning. That.
Yes, I went to the barber and gave it a haircut. All it does is extend the workroom.
Thank you.
To the bill sponsor, would you say that that's going to allow, to Delegate Szeliga's point, that's going to allow the governor's cabinet to more efficiently and strategically use those funds in advancing the recommendations that's coming from this group, so that they're actually being strategic about how they are
How to spend
implementing?
their resources, yeah. Yes, I would absolutely agree with you.
Okay,
Did I cut you off? I didn't mean to.
No, you were perfect. Thank you so much. Is there any further discussion on this bill? We're on the bill as amended, correct? Yes. Okay, thank you. All in favor, say aye. Aye. Anyone opposed, go ahead and raise your hand. Is there anyone who does not want to be on this bill? Delegate Szeliga? All right, thank you very much. All right. Oh. Delegate Kipke.
I was looking at Delegate Lopez, and I was thinking of her bill yesterday, but on HB 811, I'd like to be recorded as no.
Okay, so let the record reflect HB 811 is, that Delegate Kipke is a no.
Thank you.
Got it, thank you. And Delegate Morgan, you do not want to be a co-sponsor on 866, got it, thank you. Anything else? All right. No, I appreciate it. Keep us honest. It's much easier to fix it now than fix it in post. House Bill 1012. This is Public Health Local Suicide Fatality Review Teams authorization. Chris, take a deep breath, and Hill.
Thank you, Madam Chair. This is a long one. This bill authorizes a county or municipality to establish a multidisciplinary and multi-agency suicide fatality review team to prevent suicide deaths by reviewing the deaths that occur within a county, identifying factors associated with risk of suicide, promoting coordination with different entities, and developing recommendations to prevent suicide. 2 or more counties can establish a single multi-county team, but they must execute a memorandum of understanding on membership, staffing, and operation. The bill outlines membership of a local team, requirements and recommendations for the local team operations, and requirements for use of records and data. The bill establishes penalties for violating the bill's meeting or data privacy restrictions. We did receive amendments from the sponsor. Amendment number 1 makes technical changes. Let me give you the page number, sorry. The amendments are in the packet on pages 30 and 43, 30 through 43. So Amendment 2 clarifies that the bill does not supersede or limit the authority of local child fatality review teams and confirms those teams retain primary authority to review deaths of individuals under the age of 18 while allowing joint reviews. It establishes requirements for local suicide fatality review teams, including quarterly meetings, data collection and secure record storage, reporting to the Maryland Suicide Fatality Review Committee, and coordination with local child and overdose fatality review teams. It clarifies the scope of reviews to include deaths of county residents as well as deaths occurring within the county. It authorizes information sharing with other public health authorities and allows local teams to request relevant records from certain individuals, healthcare providers, and local government agencies. It provides limited immunity for team members participating in the review process and exempts team records from discovery or use as evidence in legal proceedings. And finally, it clarifies that local teams are public health authorities subject to HIPAA and authorizes the Department of Health to adopt regulations to implement the provisions.
Delegate Hill.
Yeah, thank you, Madam Chair. So, and thank you, Chris. So the amendments were accepted because they address some concerns that have been raised by the Department of Health and give some clarity and make it a much more workable bill, and then amendments being taken up, the bill passed unanimously. I'd like to move the amendments.
Second.
All right, amendments have been moved and seconded. Is there any discussion on the amendments? All right, seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. All right, do we have a motion on, it's been moved, do we have a second? All right, it's been moved and seconded. Do we have any discussion? Delegate Shalega.
I'm sorry, I seem to be the one with a lot of questions today. How does this protect the privacy if a family doesn't want their child's information put in a database or turned over? So it's a small county, and there's, hopefully by God's grace, very few of these. It would be very easy to identify who that would be. So how are you protecting the family's interest in protecting their child's information?
Well, the bill subjects these local teams to HIPAA, so that's one protection, right? That those records are secure and safe, and that the local teams are subject to any penalties by the federal government regarding those records. I think also the local teams are just set up to be secure. They have their own state requirement, obviously through this bill also, to keep the records secure. And they're not sharing things with the public, they're sharing things with other public health authorities. So it's all really kept in-house, and it's not really any information that's going out to people who don't need to be in on the review.
Well, then why do we need an indemnity? A person shall have the immunity from liability. So why are we giving somebody immunity from liability? If I just would work, if it was my child and I wanted to say, no, you cannot have my child's data. That's my information. Some would say it's for the betterment of public health, but ultimately that should be my decision. Is there a way for me to opt my child's information out of this?
As I'm reading the bill, the local teams can request information from parents, things that they already don't have access to, but parents are not required to share any information with the local teams that they don't want to.
But I meant some of it's going to be like coroner report, police report, that.
Right.
So I think it may be philosophical difference that I think parental privacy, family privacy should have a place in this. And there must be a concern if there's an immunity from liability section in here. Thank you.
Delegate Hill.
Delegate Shalega, as always, you bring up, a good point that if you have, we're talking about school data, we're talking about community data. If there is one murder in a community and we're reviewing the data for the year and we see that data shows certain patterns, we can all figure out that there's a person behind that. It's very different if you're talking about 230, right? And that's your point. This data is the data that's already available. This is not going to the families, whether that's the individual adult who their family members may not want the data shared either, but this is not for public consumption. This is for the folks in the group to be able to do the work to help the local jurisdiction make better plans for how they can be more effective. So you're not wrong. You're not wrong. And the immunity is there is because you're not wrong. Because they're not going to families and saying, can we have permission to use your data? We're taking it out of the available sources. if it were to get out, then it might be identifiable.
Delegate Alston.
Thank you. I just want to make sure that the data is disaggregated.
Yes.
Okay. And is there a way when families are filling out forms, like you have to get death certificates and other forms after a person transitions, that they can say they don't want the information shared, like a box they can check?
I'm not aware of anything like that. Public health data is public health data. Whether we're talking about venereal disease, we're talking about drug addiction, we're talking about suicidality, it's the public data, and those are the statistics that we use. And we don't get to opt out of the public data.
Okay. Thank you.
Which is different, to make the point, and you get it. That doesn't mean it's the publicly available data, right? That's why we have, you have to apply if you want to have access to that kind of data. That's why we have so many groups coming to us every year. I don't know why not this year, about, PIA requests and what has to be shared.
Because we don't have that anymore.
It went to
GLE.
That's why.
They're in Legoland.
Delegate Riley.
And after all this conversation, so the data that's included in this bill, my understanding is that it's data that's already there, and now the counties can have a group that can access it individually, and then it can also be shared with the current statewide, I guess, group that actually currently get the data. So this is all public data already. They're just kind of massaging it and allowing the counties to get more information per county or city. And if their name was redacted before, it's still redacted, correct? Okay, so this bill doesn't change that. It doesn't, so if the name was not there, they cannot get the name. Correct. Okay.
To Delegate Shalega's point, if I know it's from Howard County, if it says 2 teens, 2 people, death between 14 and 20, Howard County, gunshot wound.
Right.
We know we only had 2 gunshot wounds in Howard County, so I can figure out who those 2 people are.
Right.
Right.
But it's not
But it's
going to be in the
already there.
report
You're
that says
100%.
so-and-so.
You sound like someone preparing for the floor defense. Thank you very much, Delegate.
Delegate Taveras.
I think my question was just answered. I mean, at the end of the day, what we're just talking about is a dashboard, and it has data in it.
It's not a dashboard. It's not public facing.
It's not public facing.
Right. This is for, Delegate Hill, if you want to restate it's who this is for.
This is enabling. Thank you. This is enabling legislation that allows what is being done at the state level to be done at the local level. So at the state level, we're looking at suicidality, and this is saying that local communities may want to do the same thing so that they can review, create programs that deal with the particulars of their community. So it's allowing them to have access to that data through these teams that they set up. And they can also share data that they may have that the state doesn't have. So there's a two-way communications between these non-public facing groups, teams.
Delegate, well, let me go to Delegate Morgan, and then we'll go back.
I'm just going to ask questions on the underlying policy. If it's already done on the state, I'm looking at the budget. I mean, we put $17 million for behavioral health, and that includes the mobile crisis team to prevent suicide. There's also some follow-up in the budget from prevention and health, different promotions out of the budget at Department of Health. Why would the counties have to do this when the state is already doing it?
So first, if I may, Madam Chair, the counties don't have to do this. So this,
Yeah, you're right.
yeah, this bill came because at least one jurisdiction wanted permission to do this. And I think their concern, and I have not spoken to them, was that the recommendations that are coming out of the state, or the picture that they're seeing from the state, may not be particular to them, and they want to know what are the issues we're having here. And so what are the programs or the recommended programs? Where should we put our resources? Because what may be happening again in Howard County may not be what's happening in Washington County. And so we want to know, what is it here? It might be different because unemployment trends. It might be different because of the mixed cultural, ethnic mix. It might be socioeconomic areas. I don't think that we can assume, for instance, that the cause of suicide in Potomac, Maryland is the same as the cause of suicide in Cambridge.
I would just assume that the state would be smart enough with the amount of money geared towards this to be able to do that. Because, I mean, they have health departments in every county. I would assume that they're smart enough, I would hope, that they would realize that the people in Potomac may have a different situation than the people at Garrett.
I think that, I don't know, but again, I think that they're making recommendations, or they're looking at the data, and they're making recommendations, and I don't think that I think if they had the ability and the funds to hone it down to the micro level, to the region, to the county, to the town, then they would do that, and we wouldn't have locals asking for it, but I don't think that's their charge.
And I think there is a parallel between like our Department of Health and our local health departments that often, utilize the resources of the State Department of Health, but they need to localize the actual, the actual programs that they do, because again, that sometimes what works when you're looking at statewide data isn't specific enough when you drill down to the local. And to Delegate Hill's point, this is enabling, so it's not requiring the counties to do anything. It's just saying if they want to, they can. Delegate Chalet.
Thank you. First, I want to say I don't think this is, quote, public data because it's protected. So is that right? When you say public data, it sounds like the public sees the data.
I guess when I'm saying public data, I'm talking about the government as being the public entity that has it.
So it's government data, not public data.
Public health data.
But public
It's
makes.
public health data.
Yeah, so maybe it's a philosophical issue, but I feel like, without an option to opt your child's information out of this, and maybe it's personal. I had a full-term stillborn baby, and I was in some public health record, and somebody reached out to me that I did not want to talk to.
Yeah, and I'm sorry about that.
Yeah, and, so I think giving people an option to say, my data is not your data is important. Yeah. So without that provision, I can't support it.
I respect that, and I think from a public health standpoint, there is value in having all the data. And otherwise we're not really doing public health.
I agree, but public health doesn't trump my personal right and freedom.
Well, that is a philosophical difference.
All right, we are on the bill as amended. We've had the discussion. Any further discussion? Thank you very much for a robust and very meaningful discussion, because these are important issues. All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Delegate Shalega, Delegate Morgan, Delegate Riley, and Delegate Kipke, Delegate Hutchinson, Delegate Riley. I was Delegate Kipke. I did, but that's okay. We want to make sure we've got the record correct. House Bill 1068. This is health insurance special enrollment period for newly hired employees of small businesses. This is Lisa and Cullison.
This bill requires certain health insurance carriers to provide a special enrollment period for an individual who has become employed by a small employer that does not offer an employer-sponsored health benefit plan. The special enrollment period must be open for 60 days and begin on the first day of employment of the individual by a small employer that does not offer an employer-sponsored health benefit plan. Coverage must become effective on the first day of the month following the date of plan selection. There are amendments on page 44 of your packet. The amendments add definitions for employer-sponsored health benefit plan and small employer, and they clarify that the special enrollment period includes dependents of the newly hired individual, and that the first day of employment will be indicated on a form developed by the commissioner.
Vice Chair Coulson.
Thank you, Madam Chair. Thank you, Lisa. So we spend a lot of time in this committee talking about how do we make healthcare as accessible as possible and trying to look for ways that reduce barriers, and that's what this bill attempts to do. So the first thing I'm going to do is move the amendments, but I'm going to amend, well, I'll move the first set of amendments and then I'm going to amend it. So move the first set of amendments that Lisa.
All right, they've been moved and seconded. Any discussion?
To add an amendment on page 45, on the form, and on the bill as written on line 25, the form right now only includes the first day of work. What I'd like to include is to certify that the employee is working a minimum of 30 hours a week, so that we don't have someone taking a five hours a week job just for health insurance. So with that, I would move that amendment.
It's been moved and seconded. Is there?
Was amended. I just want to stress, I know that there's been some discussion.
Madam Vice Chair, just 1 second. Delegate Riley had a question.
Question on your last amendment, if that's okay. If this is the appropriate place, right? So does this one change the, the opposition of any of the carriers, do we know? Because they made a good point, I thought, in hearing, and I didn't know if this would change it.
Completely eliminates it.
Okay, all right.
I mean, I think it makes it easier, but it doesn't eliminate it.
Okay.
Right, it doesn't get them to neutral. And I think, their concern is about bad actors. And, I try to give folks the benefit of the doubt, hope that they're acting in good faith most of the time. But I know that as policymakers, we need to build in some guardrails. And that form is a form of guardrail against the bad actor who's going to quit one job and go to another job. But the reason that I was supporting this bill is it's good for people to have, reduce the barriers. It's good for the small business because they can't afford to pay employee insurance, so they can guide the employee to the place where they can get the best deal on insurance. This does not provide any new subsidies, so it's not adding any, they're not taking advantage of the subsidy programs. And they have to pay for the benefits. I mean, they're not being given benefits, they're having to pay for them. And that's why I thought, this was, while it raises some questions about how people can game a system, it also provides for those who are not and who are, I say, operating in good faith. So with that, I would move the bill as amended, now that I've discussed it thoroughly.
All right, it's been moved and seconded. We'll open it up for discussion. Delegate Hill.
Thank you. Madam Vice Chair, the basic premise that if someone is sick, whether they just find out and they get insurance, isn't it less expensive for taxpayers that the person is on insurance than that they're not on insurance?
Yes.
Okay. So we want them on insurance.
Yes.
Okay, and we want them to get the proper treatments early.
Yes.
So that okay, thank you.
Is there any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. To the bill as amended. Delegate Shalega. Delegate Riley. Delegate Morgan. Make sure I got everybody. All right, and this bill is amended. Who does not want to be on the bill? Delegate Shalega, Delegate Morgan, Delegate Riley. All right, thank you very much. House Bill 1263. This is Public Health Work Group on Post-Operative Cosmetic Care. Chris and
This bill establishes the work group on post-operative cosmetic care to study the regulation of post-operative cosmetic and body-altering services provided by non-physician practitioners with a focus on patient safety, consumer protection, and continuity of care. Members of the work group representing government agencies must designate staff from their respective government entities to staff the work group. The work group is not a regulatory board and may not establish a licensure program without legislative approval. The work group must submit by December 1st an interim report, and by December 1st next year, a final report of its findings and recommendations to the Governor and General Assembly. The bill takes effect July 1st and terminates June 30th, 2028. There was one amendment to add a licensed acupuncturist to the work group membership.
Delegate Hill.
Thank you, Madam Chair, and thank you, Chris. So that's the bill. And no significant fiscal note. The amendment was voted unanimously. The bill was voted unanimously. I'll just note that the Department of Health had indicated that they could do this, except that they weren't doing it. And when we spoke to all the boards, they all acknowledged that this was a problem. And the physician board heard this before we put a bill in and said, yeah, this is a problem, but it's not one that we should be taking on, and that's why the work group, because everybody agrees it's a problem and nobody has jurisdiction. I'd like to move the amendment. Second.
All right, amendments have been moved and seconded. Any discussion on the amendment? All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended. All right, it's been moved and seconded. Any further discussion on the bill as amended? Seeing none, all in favor say aye. Aye. I was going to say opposed. Delegate Szeliga, Delegate Morgan, Delegate Kipke, Delegate Riley, Delegate Hutchinson. Who does not want to be on this bill? Delegate Szeliga, Delegate Morgan, Delegate Kipke, Delegate Hutchinson, Delegate Riley. Thank you, everyone. House Bill 1364. This is Public Health Mammograms Arterial Calcification Notice. Chris and Hill.
This bill requires a center where mammography testing is performed to include in a screening results letter that is sent to the patient as required by federal law, a specified notice about breast arterial calcification. There was one amendment, and the amendment moves the arterial calcification notice requirement to a new subsection so that a provision that only applies to the current law regarding dense breast tissue does not apply to the arterial calcification notice.
Delegate Hill.
The amendment passed unanimously. The bill as amended passed unanimously. And I'd like to move the amendment.
All right, it's been moved and seconded. Is there any further discussion on the amendment? All in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. On the bill as amended, do we have a motion? Second. All right, it's been moved and seconded. Any further discussion? Seeing none, all in favor say aye. Aye. Anyone opposed, go ahead and raise your hand. Who does not want to be on this bill? Smart group. Yeah, you don't want to be a sponsor? Okay. Delegate Morgan and Delegate Szeliga, let the record reflect that she's not here, so we'll make sure that, yep, perfect. All right, so that concludes our voting session. Go ahead and let me know when we're down. Thank you, everyone.